AUA to work with you here in Saudi Arabia and providing this update. And I understand it comes in blocks, and this is always very painful for the audience because there's going to be 2 hours, a marathon on LUTS and BPH, and then a marathon on ED and penile reconstruction and whatnot. And so it's a little difficult because you have to listen to one person for a long time. But fortunately, in my area, in LUTS and BPH, there's at least differentiation between medical management and surgical management and those kinds of things. So we'll try to keep it a little bit entertaining and varied. So I was asked to, instead of having a breakfast with the residents, I was asked to pick one of the topics that I suggested that I had talked about, and it's called How to Read a Journal Article and how to decide if you should pay attention. So, and I'm going to spend about 30 minutes on this, and maybe there's something in it. This is not really a knowledge talk, so it's not anything where you can take notes or anything. It's more like, okay, so maybe some tidbits and some kernels of wisdom that you can take away from that. As a general idea, I'm of the opinion there are too many journals out there, and this is a problem because you can't read all of it, or not even half of it or 10% of it, and it's already difficult enough to read the key journals. And the problem is that every subspecialty has a journal, every organization wants to have a journal, many people want to be editors or associate editors, and there is some money in it due to advertisement, and sometimes in European countries there is promotion that is based on how much you publish. So not everything that is published is new and newsworthy, and you'll have to sort through it. And when I read the literature, and I'm doing this now for 30 years, I come to realize that many articles, they fall into one of these categories. So the first category is, I read this article, and I tried this also in my own patient, and here is the result. So this is like a Me Too type of thing, and it's not always anything new. And then comes this thing where, we had this interesting case, one of our residents looked it up, we found 10 more, and here is a case series. And so that's how so many of these case series come to be published. And then comes this research where there isn't really any meaningful results, but maybe there is a p-value, and so the data get published even though there isn't anything practical that comes out of that experience. So there's many reasons and why the literature is so replete and why there's so much published in this space of urology, and not all of it is really necessary for us to read and for us to study. So what I do and what I recommend my residents and my faculty or fellows to do is to set up literature searches, and I'm sure many of you will do this or you're familiar with it. You can do it through Scopus or PubMed or GoPubMed or Google Science or many of these services. You can set up monthly or quarterly searches in areas of interest, and then you can scan what's available and then directly download it, and I'm sure that's also widely available into Reference Manager, so you can organize it in categories. So I use, for example, a lot of Scopus.com. I think that's very useful for me, or PubMed, and then I use EndNote to categorize it and having it available by keyword, etc. So a different way to ask the question about how to read the literature is, how would you write a paper? How does one write a good paper that passes editorial review? And this could help us also to understand how to read the literature and how to make the most out of it. So when writing papers and when looking at the literature, there are guidelines out there, and guidelines in regards to how to do a trial, how to set up a trial, and how to publish a trial. And some of them are internationally recognized. So for example, if you publish in JAMA, the New England Journal of Medicine, which is a lofty goal for most urologists, you can't do it if you don't follow the consort principles, which I show here. The consort principles outline how a trial has to be presented, how the data have to be presented, and there is, for example, this flow diagram in the consort statement, without which you can absolutely not publish an article in JAMA. They will immediately send it back to you. A flow diagram that shows where the patients went, how many were treated, etc. They're very detailed informations. So I would say, when you look at this, this consort statements about publications, scientific publications, and apply that to the literature, you can already see which papers are worth reading, which papers are well done, which papers are not well executed. And you can see this runs through the interventions, participants, the outcomes, the sample size, the statistical basis for the trial that oftentimes is not really done very well, randomization, etc., etc. So all these points are addressed, and all these points you can read and inform yourself how it should be done, and then see whether or not the authors adhered to these types of recommendation. This is an example for a consult statement, and for a randomized trial or a controlled trial or any kind of treatment study A versus B, it's a must. You have to just start with the patients that were eligible, the patients that were excluded, why they were excluded, the patients who were ended up randomized, and then how they were treated, how many were followed, how many dropped out of their follow-up, etc. If you don't have a statement like that in a paper, and so the authors say we treated 200 patients and here are the results on 85, you ask yourself, what happened to the remaining 115 and what's going on with those? So if you don't have that statement, the paper is, subject to some scrutiny, because obviously there is a selective data reporting, and it's not necessarily the entire database or the entire cohort of patients that is presented there. So I always am very keen on having such a statement in every paper and such a table as a very first table in every paper. So when you read the Journal of Urology, you read Urology, or you read the British Journal of Urology or European Urology, the leading journals in the field, you will notice that many of them, or if not all of them, mandate that, and most of the good papers have actually such a algorithm in there how the patients were allocated. There's a description, a very detailed description how baseline data should be presented in the two different groups, if there's comparison groups, means and medians and ranges of observations that have to be presented, etc. And there's also there's ways in which the editors that have come together to form this consult statement try to homogenize a little bit and make it sure that everybody publishes in a very reasonable and scientifically solid way. Now, when you publish, on the other hand side, you ask yourself, how do all these papers get in the journal? Well, they got through an editorial review, and the associate or assistant editor reviews it and recommends it for publication. The editor accepts it, gets published. And so the question is, what do reviewers want, and how does it get in there? So there is no point in answering a question that nobody is asking. So the most relevant, important papers are those that change practice. It's pretty obvious. High-impact papers obviously concern healthcare issues affecting large numbers of patients that have large effects on quality of life or mortality or have substantial economic cost. And it must be in some ways novel. There's a trade-off between originality and relevance. The better chance of publication is if the importance is great, if the originality is not, or if this is a verification study, if you will. So the interesting thing is that the editorial review process is actually very well established in medicine and in urology and the urological journals, but it is not all that clear that it's a good process, and it would filter through the editorial process really represents the best there is and the best data there is. And this here is a systematic review. It's now 14 years old, but it was published in JAMA, a very established, very high esteemed journal. And it was called The Effects of Editorial Peer Review, a systematic review. And if you read just down here the conclusion, it's kind of shocking. They say, although widely used, editorial review per se is not untested very well, and the effect is uncertain. The effect on what? The effect on the quality of the publication. This is my experience in urology as well. Not because there's an editorial board, that doesn't necessarily mean that what made it or didn't make it through the editorial process is or is not the best material. So that's again puts the burden on you or on us urologists or learners in urology to go through those journals and seek out what is actually the relevant information. Let me go through a few tricks and tips and pitfalls of the urological literature that I've seen over the past and that I think are very worthwhile to remind ourselves when we're reading our papers in the journals. Sample size and power calculation. It's interesting that even in 2017, the statistical section of most our urological papers are still very, very poor, I would say, in general. meaning that the statistical method, what sets up the sample size and the power for the study, etc., is either not addressed at all or it's addressed very poorly. So every trial or every study that is done should start with a research question, and then you should ask the question, can I answer this question? And you can only answer the question if you have enough patients or enough experiments to answer the question in a statistically valid way. And so when tests are applied to groups or multiple groups, you have to do sort of a two-tailed test because you don't know which direction things go. And internationally, the world of statistics has accepted an alpha of 0.05 as a criterion of that's significant, that means something. So it means the result is significant, even if that result could have been achieved by chance in 1 out of 20 cases. So 19 out of 20 times you're correct that this is a meaningful result. There's also a corollary to that, it's called the beta. The beta also is 0.05, meaning that a significant result could have been missed in 1 out of 20 cases. So this is important because this is just a convention. Statisticians have agreed on that and clinicians have bought onto that. And we'll tell a little story. Last year I tried to publish a paper where I tried to duplicate a result that was published by Muta Isa about shaking the biopsy needle in formalin, and he demonstrated that it reduced urinary tract infections from a transrectal biopsy. And so he showed that in a paper in the Journal of Urology, and it turned out I had done hundreds of biopsies with the formalin washing and hundreds of them without in 2 different clinics, just by happenstance. So I looked at those data, and it proved to be that the formalin shaking of the needle reduced the infection risk. So I submitted this paper, and it didn't have a p-value at 0.05. So I said to the editors, in this case, I suggest to ignore the 0.05 because the formalin washing of the needle cost nothing. It is completely cost neutral. It doesn't add any adverse effects, and it doesn't add any time. You just do it in between the needle passes, and the formalin is already there because the needle biopsies are in the formalin. So I argued, I said, if I'm wrong, and if this is not better than not formalin washing, there's no harm done, because it just costs no money, doesn't take any time. Well, it's interesting to note that the editors of 3 major urological journals declined that argument. So they were sticking to their guns and said you have to have an alpha of 0.05. To me, that's actually not the meaning of this alpha. The alpha of 0.05 protects us from getting data that are possibly true, but not necessarily true, when there is money at stake, when there is drugs and surgeries and therapeutic interventions, side effects and so forth. Then it's very important to be very strict and to have an alpha of 0.05 so that you can be sure 19 out of 20 times that result is really statistically meaningful. So even the little things like our p-values and where they come from, you can ask yourself where this all comes from and whether it's relevant to a given type of intervention. So when setting up a trial, you ask yourself, what is the parameter of interest that needs to be examined? For example, changes in scores or in categories or comparison between 2 groups. And so the interesting question when I read in my field in BPH is, people don't often ask the question, what is really a meaningful and reasonable difference? So for example, when you look at BPH, a symptom score of 1, well, it's a difference maybe between A and B, but it's not a meaningful difference. So a difference of 10 points between 2 treatments is certainly meaningful for the patient between treatment A and B, but it's unreasonable because if you take 2 drug treatments, they will rarely differ by 10 points, right? There's barely a difference between surgery and medication of 10 points. So you'd have to find a difference in your parameter of interest that is both reasonable as well as achievable. And it is not one that is clinically irrelevant, like, for example, a symptom score of 1 point. That's actually very tricky because when you do that and you set that up as your primary endpoint, and that there's only one primary endpoint in every paper, everything else is secondary endpoint, and the sample size is focusing on that very first primary endpoint, And it will drive the sample size, and it will be the only one that determines whether the study is significant. So we have to think about it very clearly. And if it's, for example, that symptom score, here's a table that shows you a sample size and power calculation when you were thinking of a clinical trial. So let's think of a clinical trial, and so you think you want to compare like some kind of an herbal supplement for LUTs or BPH with like a standard treatment, like an alpha blocker or something of that nature. So if you think it is reasonable that a symptom score difference of 3 points with a standard deviation of 4, that's sort of the difference that you think is reasonable, where you would be convinced there is a difference, with an alpha of 0.05 at a power of 80%, you need 29 patients per group to show that difference. Well, it turns out the symptom score oftentimes has a larger standard deviation in your patient population. So the standard deviation could be 6, and if it's 6, you need already twice that many patients, 69 patients per group. You be very careful. And if the difference between the two treatments isn't as great as 3 points, let's say it's only 2 points, well, then you're already up to 191 patients. So what you set out to show and how much of a difference you think you can show determines how many patients you have to enroll. I think you'll agree with me when I say that perhaps 70-80% of our literature goes backward. They say, we happen to treat 200 patients or 100 patients, and we compared the results of treatment A and B, and here is the difference. And unfortunately, in many of these cases, they have no power, statistically speaking, to claim that result, because this table would give the background for that. And I assure you, if you look at the literature, many papers do not enroll the necessary number of patients to claim statistically that this really is a difference. This is a very important table to look at. And you can do this for anything. You can do it for categories, you can do it for percent changes, and any thing you want to mention. So many trials reported in our literature and in other literatures do not have a statistical method that is well worked out. And when you back calculate, the numbers are insufficient, and the changes reported are sometimes not meaningful or reasonable, and sometimes they are reported as significant because they got a quote p-value, but it turns out the number of patients is not high enough so that they cannot claim that with an adequate power. Do you as a reader necessarily know that? I would say not always. You can only guess that secondarily. If they didn't give you a sample size and power calculation, you can only guess it by the number of patients that were involved in the trial. And you can say, well, that trial is unfortunately not answering the question that was there to be answered. So urology is an area of medicine where we treat diseases that are cancer, and we can take it out and we can cure it, or stones, we can remove it and they are gone. But we also treat quality of life diseases. BPH is one for sure. The symptom score is subjective. Incontinence is by and large a quality of life. There's hard measures, but there's also soft measures. ED is the same thing, soft measures. So in much of urology, in our daily practice, I would say, what we see a lot, LUTs and BPH and prostatitis and incontinence and so forth, we deal with quality of life diseases. And in those diseases, there's a ubiquitous phenomenon that enters our thinking and our analysis of data, and it's called the placebo effect. So the placebo effect goes as follows. If you give a treatment to a patient for a certain disease, you exert a direct effect that is not a placebo effect. So you'll take a drug, and the drug lowers the blood pressure, and that's a direct effect. But the treatment also has side effects. So for example, you give a diuretic for blood pressure, it lowers the blood pressure, but it also has a side effect. In this case, it lowers, let's say, potassium. So it's possible, right? So you have a side effect of that treatment. Then there are incidental treatment factors, and the incidental treatment factors may affect, by a placebo effect, the target disorder, right? And there would be a positive effect on the target disorder. So just by the patient coming to a doctor or seeing a nurse, this is reassuring, and she goes over the history, measures his pressure and so forth. So sometimes when patients come to doctor's visits, over time, the blood pressure will be positively affected just by incidental factors, going to the doctor, being in care program and being, in some way affected. So these are incidental effects, if you will, and placebo effects. And the placebo effect or incidental factors can have both positive effects, called placebo, and also side effects. Sometimes they are negative effects, and we would call them nocebo effects. So the placebo effect is incredibly strong, and there was an experiment that I like to quote from many, many years ago, where a professor in a psychology class gave his students pills, and he said, you take these blue and pink tablets, and they weren't told what they would do, and they basically reported back, and they said those with blue tablets said it had more of a sedative effect, and those with pink said it had more a stimulatory effect, and those who took 2 capsules versus 1 had a stronger effect. And he didn't tell them anything about what was in these pills, and both were placebo pills. So this was actually in a class on the placebo effect, and the students were aware that this existed. So it shows how strong this is and how common this is. There's many characteristics and determinants to it that I list here, but in urology it is extremely strong. And I show you here a graph that I actually published, and it shows basically how strong the placebo effect is in BPH and LUT studies based on the symptom score. So the placebo effect is stronger the higher the symptom score is at the beginning. So the way you'll read this is if you have a patient population that starts with a symptom score of 20, the placebo effect alone is 3 or even a little greater. If it's 15, it would be 2. And if you start with very symptomatic patients, 25 to 30, it could be as high as 5 points. And that's an effect that's just induced by the patients coming, enrolling in a trial, giving some treatment, etc. So it's a very, very powerful effect indeed, and it needs to be always considered. Now, the part of this placebo effect is what is called a regression to the mean. And this is also ubiquitous in our literature. And I'll give you an example for how that works, actually, the regression to the mean. And I'll give you later on, then I'll tell you how this works in treatment trials, whether it's ED or BPH or incontinence or any kind of quality of life disease. So what I did is basically I took some volunteers and I asked them to do a couple of flow rates and fill in symptom scores a couple of weeks apart without any kind of treatment and without any enrollment criteria. There were any volunteers that could have any symptom score, any flow rate they wanted. And there were actually no differences between the first and the second. You see this 12, 11.7 was a symptom score, and the flow rate was 17.6 and 17.5. So they were not BPH patients. They had a normal flow rate, and they had a low symptom score. And there was no difference between the first and the second measurement. Now, the problem now is when we do a trial, that's not what we do. And this is the main point of this message. When we do a trial, we don't enroll every comer. We enroll patients who we like to treat because they have the disease. So we treat patients that have a higher symptom score than 12 points or 10 points or 15 points. They have a lower flow rate than 15 or whatever the cutoff may be. And in ED, you enroll patients with a SHIM score that is no greater than 25 or 22 or 20. And in incontinence, you enroll let's say in an OAB trial, you only enroll patients who at least urinate 10 times a day, right? That's what we enroll. So if you basically take this group of volunteers and you exclude everybody who at the beginning had a symptom score of less than 12 points, okay? You exclude those. Well, at the end of the day, those patients when you excluded those, ended up with a statistically lower symptom score the second time around. Because the second time around, you don't apply any criteria. You say, okay, this is your second test, this is the alpha treatment test, and so anything counts. So here you exclude everybody under 12, but here you include all comers. And the more restrictive you are with your patient population, the greater is this regression to the mean effect. And it's an absolutely phenomenal thing, and it shows here when we use a restriction of greater than 7, greater than 10, or greater than 15 points, and it demonstrates that you actually can induce completely artificially a statistically significant symptom improvement. So for example, if you put on a restriction on a symptom score of greater than 10, the group will have 19.9 versus 18.8, and if you do have a symptom restriction of greater than 15, it will be 21.9 versus 20.6. So just by applying a restriction criterion, you can sometimes induce a statistically significant difference. And nobody in the room would say these people had a successful treatment. All we did is we restricted them at entry, but not at exit, and as a result of that, we induced an effect. So when you read a paper on a new treatment for ED or for OAB, you know that about 20% of the effect is a regression to the mean. Has nothing to do with the drug, nothing to do with the surgery, nothing to do with the treatment. It is simply a regression to the mean induced by this restriction in the enrollment criteria at the beginning of the trial. And you can see here that by t-test, you reach significance here, less than 0.05, less than 0.05, less than 0.05 regarding the symptom score, and amazingly enough, the same is for the flow rate. You reach significance if you exclude people with a flow rate under 15, under 12, or under 10, and you reach significance at 0.05. And seemingly, these people have a symptom flow rate improvement. It's incredible. Now, when we look at our literature, and we look at the issue of adverse events in our literature, I would say that this is in general in the medical literature poorly reported. And I'll tell you why I think that. The surgical literature has recently improved, and many journals, fortunately, have now decided that they only accept papers that report on the Clavian-Dindo classification for surgical complications if it's properly in a table annotated, and I certainly agree with that. But in the medical literature, that doesn't exist. So adverse events reporting is problematic. Adverse events are health events taking place during the time of treatment, whether or not they're related to the treatment, and side effects are effects of a drug on a specific organ system other than the intended one. So it's in that placebo effect that I gave you a moment ago. There are more adverse events, healthcare events that take place that are unrelated, and in many trials, as many as 50, 60, or 70% of men have adverse events. They are not necessarily treatment-induced side effects, but they are adverse events that take place during the trial period. Now, the issue is, how are these things reported in our literature? So, most of the side effects from drugs and surgeries and interventions that we do are basically not elicited, but are spontaneously reported by the patient. And if you let the patient spontaneously volunteer side effects versus you ask him a standardized laundry list of possible side effects, you will get very different results. If you ask a standardized list, there usually will be more side effects than if you ask the patient just to spontaneously report. The counting is problematic in our literature. The total number of adverse events is often greater than the number of patients because some patients have more than one, but it's not always clear what is reported. And the timing is important because some adverse events take place early, some take late, and it's important to differentiate the two. So for example, if you tell a patient, I'll give you this drug and I want you to take it for the next 5 years or for lifelong, and the patient asks, will there be side effects? You say, well, yes, there will be, but they're usually short, they go away after a month, or they say, well, this is a side effect that you always have. So it makes a big difference for a patient if he knows those kinds of things. So most studies report side effects in a big table that they hear side effects 1, 2, 3, 4, 5, and this is the total percent of patients or number of patients that had it. So instead, I have strived to publish and continue to do so the side effects in the following way. I provide a table that gives the months, and you can see that here, and the 2 treatments, and then the number of patients that are available for follow-up at those time points, and then how often these side effects A, B, C, D occur. So when you look at this, for example, you can see that some of the side effects, like for example A, there is, the same number that takes place in a drug and placebo groups throughout the 12 months of the trial. But here, for example, B, the drug arm has early on some side effects, and then at 6 months some side effects, but the placebo arm has none. So it's clearly a drug-related side effect that is persistent. And then there are some side effects that come on late, as shown here, and other side effects that are just very rare with both drug and placebo arms. And the key now is when you have the number of patients here that are available for follow-up and the number of patients with a side effect in these time periods, you can calculate the occurrences per patient months. And it's a very fair and balanced way of reporting this. Because keep in mind, in many trials, a year or 2 or 3 years out, there's only 50% of patients available for follow-up. And only 50% of patients can have side effects. So you express the number of side effects per available patients per time period. This is not done, and this is actually sort of I would say a dream of mine, that this would be a standardized way of side effect reporting. But in recent papers, I could give you some examples, I have done this and others have done it as well. For example, the Rhizome paper in the minimally invasive space of BPH has done it just recently exactly in that way. The same for the UroLift procedure. We'll just briefly talk about this, the reporting of outcomes, the primary outcomes. When you look at a paper and you look at the primary outcome reporting, let's say it's a symptom score, so you want to report the time points, and you want to report the absolute change, and you want to report the percent change, and you want to report the p-value from baseline within the group, that is here, and you want to report the p-value for comparison between the groups. This is not always done. But if later on somebody goes in and wants to do a meta-analysis, which is very popular these days, you have to have all these components. You have to have the absolute values. You have to have standard deviations. Otherwise, nobody can do a meta-analysis with your data. So to reporting of absolute changes, percent changes, and p-values from baseline as well as group comparisons are absolutely a necessity. These are just the text boxes that report that. There's another way of reporting outcomes when it's a numerical score or a categorical score. For example, a flow rate, a symptom score, an OAB diary or frequency volume diary or whatnot. And that is shown here. It's a cumulative frequency distribution. I personally think that is an excellent way and an honest way of displaying data. And it's not really very much done in the literature. You've not seen this type of graph. I want to walk you through this for a moment. On the x-axis, you see the symptom score changes, IPSS score changes, for 2 different treatments, a microwave treatment and a sham treatment. And what you see is the cumulative frequency of patients who reached certain changes. So for example, when you draw a line here at -3, that would be the improvement in symptoms by 3 points, sort of a threshold, a marginal threshold that is considered significant. You can see that with the TUMT treatment, it's about 85% of patients who achieve that, but in the sham treatment, it's 55%. Okay? Similarly, you can ask the question, 50% of patients achieve what improvement? 50% of patients achieve an improvement of about 12 points, and 50% of patients achieve an improvement about 6 points with the sham treatment. So you can look at it both ways. You start with a symptom score change, or you start with the percent of patient. But it also helps you to understand what percent of patients, if you draw this line, actually experience worsening of their symptoms. Because clearly anybody who has an increase in the symptom score of 3, 6, or 9 points represents a worsening. And you can see that this involves 20% of patients who got worse. If you present a bar graph on this with the mean changes from baseline, you will never learn that. Here you can learn for any threshold you pick what the proportion of patients is who have that threshold, and you can see what proportion of patients actually experience a deterioration. This shows the same idea, but instead of an absolute change, a percent change. And so again, you can ask the question, 30% improvement, it's in 40% of placebo group, 70% of the treatment group, if that's your threshold. So it's a very quick and easy way, and again, you can show also what percent of patients have a worsening. Again, it's 80%, and in the treated group, it's about 5%. 95% have some improvement. So I spent a little time with some ideas of how I think about setting up a trial, how I think about designing a trial, about the sample size, the power calculation issues, and what I think before I submit a paper for publication. And I believe the editorial process is here to stay, and you have to get your presentations through your papers through the editorial process, whether it's good or bad or neutral. And there are some general comments I want to make. There are 3 relevant parameters. When you look at a paper, you write a paper. It doesn't matter. You read a paper, you write a paper. It has to be relevant, it has to be original, and there has to be a research question that is clearly phrased. Sometimes you read a paper and say, what is actually the question here? You should read a paper and you think about how you would write the paper, and it will help you in your understanding of it. When you read or you write, you should ask yourself the question, is this material presented, like for example in a consort statement, and the tables and graphs are all presented in that way that I outlined here? Look at the p-value and ask yourself the question, what does it really mean that there is a p-value? Did the authors tell me that they have the power to claim this p-value? Did the authors demonstrate they enrolled enough patients to be sure about that? Or is this basically a post hoc statistical analysis of a chance data set, in which case the p-value may be a p-value of 0.05, but there is no power and they can't claim that this is actually significant. This is actually the most common error, in my opinion, in the literature. Be very wary if there is no data of the given regarding the range of variation or the measure of variance, whether it's a standard error, standard deviation, inner quartile ranges, or confidence intervals. Even today, in some of our literature, you see just mean or medians, and I'm always very skeptical when I see that, because I don't know what the scope of the observation is and what the range of observation is. Be aware of the common traps, the placebo effect, which is very powerful in a large part of what we do in neurology, and the regression to the mean. Keep in mind that if you read a paper and it uses any kind of numerical score or categorical outcome, and if it compares two treatments, 20% of the effect is a regression to the mean. And it's a mathematical fudge factor, if you will, that's induced by enrollment criteria. So you want to be particularly leery if people say we enrolled very symptomatic patient. I will one more time get back to that. If you have a drug that you think may have an effect on overactive bladder, and you only enroll patients who urinate 15 times a day, which you will agree is a lot, you will show a regression to the mean effect just by doing that, and it will look statistically significant. You have to be careful that the enrollment criteria are not too stringent, because too stringent enrollment criteria will induce a greater regression to the mean effect, and it will basically minimize the drug effect, or the drug effect is hidden behind that regression to the mean effect. So I'll leave you with these thoughts, and we'll have a couple of minutes time here for questions regarding this very difficult topic of the urological literature, how to read it, how to interpret it, how to contribute to it, and I'll be happy to try to address it from my experience. As you may know, I've been associate editor in urology. I review for all the journals. I have never been editor of a journal, and I have avoided that actually because it's very time consuming, and that hasn't been my primary interest, but I'd be happy to try to address questions that you may have. Yes? Yeah, I think that that it's too late. If you have a paper or you have a study, and then you say, so how do I submit it to the journal? That's one step too late. a mentor, a senior urologist or advisor has to work with a resident or a fellow before. When somebody has an idea or a question and comes to me and he says, I wonder what influences the rate of failure to void after a TURP. I said, okay, I think that's a good question because it's very upsetting. If a patient has a TURP, the next day you can't urinate. That's really irritating. That's a good question. So my first question to that resident would be, so what are you thinking about? He said, what I was thinking about, I look at the last 100 TURPs. And I said, okay, and then I write it up. And that's not good enough. So you have to ask yourself, A, what is the outcome that I'm interested in? And then you have to ask yourself, do I have patient numbers to demonstrate what makes a difference there? So then let me go into detail with this little example. So I say, here's what I would suggest. I say, if you want to know the answer, the first thing you do is you ask yourself, how many TURPs were done in your hospital, in our hospital, in the last year or 2 years? If it's 50, forget it. If it's 200, you may have a chance. That's the first question. Do you have the patient population? And then you ask yourself, what do you know about the TURP? So we have an electronic medical record. You may too. I don't know how it works, but you too. So many things are captured. And then I say, what do you think influences post-retention, post-TURP retention? And he says, well, age of patient. I said, yes, age of patient. What else? We have that. And then what else? Grams resected, possibly. Time resection time. I said, possibly. Do we have it? Yes, we have it. What else? Type of anesthesia. Do we have it? Is it spinal? Is it general? Yes, we have it. We can do it. And then I would say, what else could affect it? Size of the prostate, type of bipolar, monopolar, who knows, And so we ask the question, do we have all these parameters that we can look at and we can analyze? And then the question is, what do we define as post-op retention? The next morning you stop the drip, you take the catheter out, patient can't urinate, he's in and out cast once, and then he pees and he's going home. Is that a post-op retention? Or is it only a retention if he can't urinate the first time, the second time, and goes home with a catheter? So we define that. So by that time, that resident is usually pretty aware that the simple question is not so simple, right? And I think that's where most the publications fall short. So when that resident now goes into the electronic medical record, and he analyzes the last 200 TURPs, and then he says, and here's what I did. We had 200 TURPs, and 30 of them had a post-operative retention. They failed to urinate the next day. So I say in my mind, 30, 170, 30, that may work. That's an okay number. If it's just 5, it won't work, right? But if it's 30 and 170, that may work. And then the paper will say, we did a multivariate analysis of factors contributing to post-op retention based on age, resected volume, bipolar, monopolar, type of anesthesia, spinal versus general, that's categorical, size of the prostate, that's numerical, and duration of surgery, those kinds of things. And here are the results. That will fly because it's a sound statistical basis and we know there's enough patients to answer the question. So you ask me the question, what do we advise our residents how to submit a paper, how to prepare it for submission? And I answer, making sure that the residents, the fellows, the learners have a topic, a material that actually they can write a meaningful paper. And so they don't come to you with a paper and you say, well, that's never going to work because you didn't ask the question correctly, you didn't collect the data correctly, and you have all kinds of knowledge holes. Yeah. So maybe it's a cop-out when I say that, but I would say a successful submission of a paper to a journal starts with the proper way of asking the question and determining whether you have the patient, the data, and the know-how to analyze it and set it up properly. And very rarely, if you'll set it up and you'll start out with the way I stepwise said, with the factors that could contribute, the numbers of patients, and you have a balanced population, very rarely will that fail, you know. Then you will be successful. Now the paper has to be also written correctly. So for example, when you take this example, you have to have a consort diagram, so many patients had a TURP. We excluded those patients because, I don't know, some had an SP tube, you know, some had a channel TURP for cancer, we excluded those. You know, all the little tricks that go into this. And so many patients were followed, then you have a baseline data, and you have your outcome table, and I think you'll be successful more often than not. But the key is how it all starts, you know, and so I try to bring this home to our residents by saying, when you have any idea, any notion of any academic thing you want to do, first phrase the question and tell me what it is. And I'll tell you, together we work it out whether we can answer the question. Or we can rephrase it, you know, in some way and make it manageable for us. Any other questions or comments about this topic? You know, it's how difficult it is. You know, European urology accepts, I don't know, 25, 30% of papers. BJU International is very low too, 40, 50%. And so all the journals are very restrictive, and it's a very difficult business to get papers published. Despite of that, you might agree with me when I say that many of the papers are of very little interest. They are Me Too papers, as I said in the beginning. They're strange case series, and I don't know how they get through the editorial process. You know, something fell short there. So we have this problem that we have seemingly not enough space in the journals, and the space that there is filled with sometimes stuff that is not very relevant. Mm-hmm. Well, I personally don't do it by impact factor. Some people in Europe, and I don't know where else that may be prevalent, promotions in academic institutions hinge on publications. So for me, that's not relevant, so I don't look at the impact factor. The impact factor is really also a very bad measure. Because it's so influenced by self-citation. I don't want to dwell on that too much, but as you know, when you submit to European urology, you have to put a certain number of references from European urology in there, and that's self-citation, and it drives up the citation index. So I look more at the question, what is this? Is this a general topic? Is this a more oncological topic? Is this in my area of prostate diseases, etc.? You know, and then I also understand that the most prestigious journal will only accept very high-quality papers. So I sometimes advise residents, I said, I would advise you to submit it to the World Journal of Urology. It's not a very high-impact paper, and you may not get there. And more recently, I also look at papers such as clinical care, primary care papers, when it's topics that are of general interest. I like to see papers published in Journal of Urology and European Urology, just like the next guy, but I recognize that there's many fields in urology, and my field only occupies a small portion of it. But I would not view the European Urology, even though their claim of the citation index is the end-all be-all. Because if you look at at other indices, there's other indices that look, for example, at scientific impact. There is no difference between Journal of Urology, British Journal, and European Urology. So the citation index alone doesn't make a difference for me. So my next task for the next 30 minutes here will be actually okay, I'm good to go though, right? Good, okay. Will be to review data from the AUA. And so I've done these AUA updates around the world now for some time. And since I have the opportunity to talk to you about medical management and surgical management, I will very strictly focus on the AUA. So these are just AUA 2017 abstract that I selected, and I'll show them to you. I'll tell you what they said, and I'll tell you what I think, and I show you some of them that I think they raised my interest and they made me think about it a little bit, okay? So in 2017, in Bloods and BPH, there was a lot of papers presented, both in abstract and podium formats, epidemiology and evaluation, medical and non-surgical treatment, basic research, and a lot of surgical and innovative surgical treatments. In total, there were over 200 abstracts presented. Now, I start out with epidemiology, okay? This was a poster session. And these folks here from Illinois asked the question, is post-operative urinary retention an independent predictor of long-term future bladder outlet procedure? I didn't come up with that point a moment ago with the paper. I knew this was my first slide, so I raised that question. It's an interesting question. Why is it that sometimes we do a laser or a TURP and patients can't urinate? So what these people is they didn't ask the question, why is that? They asked the question, what happens to these people? They looked at post-operative urinary retention in a large cohort of men, and then they asked the question, what happens to these men afterwards when they can't urinate post-operatively? And so this graph shows that if a man can't urinate post-operatively, and he is 60 years or older, that is this line, right here, I'm sorry, I'll pick up my pen again, that is this line here, okay, that those men are very likely to have a bladder outlet procedure, okay? Now, let me just be clear, I made this point about post-op TURP. These are not TURP procedures here. These are men who enter a general hospital, just like this hospital, which is 1,200 beds. There must be a lot of hernia repairs, gallbladders, colon surgeries, heart surgeries. And a lot of times people go into retention post-operatively. And this is the fundamental research question here. What is the fate of those men who have a non-prostate-related surgery and go into retention? And if those men are over 60 and they go into retention, they have a 7% chance of having a prostate procedure done in the next couple of years. If they are under 60 or they don't go into retention, that risk is very, very small. So I looked at this abstract and said, well, that's interesting. So I see this in our hospital, you see it too. You are asked to consult. A patient had an unrelated surgery, goes into retention, you ask what to do. You say, give him an alpha blocker, see what he does, and then he can urinate. But if he's over 60 and goes into retention, there's a very high likelihood, well, not a very high, but it's a higher likelihood for him to have a prostate-related procedure in the future. And so I use that. I think I can tell that to my patient. I can say, look, your odds of having a prostate procedure is a little bit higher than the average guy. So maybe you want to investigate that, look at the size of your prostate, or have you come in for a flow rate. Now, Peter Roger from Utrecht, Netherlands, asked the following question. Is there a way to predict obstruction in elderly male patients without invasive urodynamics? Now, you know, and I know that question has been asked years and years and over and over and over, and all kinds of formulas have been done. So he looked at 452 patients. He measured their prostate size, did invasive urodynamics. He measured the BOOI and all these kinds of indices. And he also measured an index that he called CLIPS, and CLIPS is his clinical prostate score. It's prostate volume minus 3 times Q max. So if you have a prostate volume of 75 grams, pretty large, and your flow rate is only 5, so it's 3 times is 15, 75 minus 15 is 60. So that would be that number. And he showed that this number is the best predictor, better than symptom score, and better than prostate size, and better than flow rate alone, to predict the likelihood of urodynamic obstruction. So to me, this is actually a bit gratifying, this paper, because in the past, people always said, size doesn't really matter. Size doesn't matter in regards to retention. And I always said, really? 100 is the same as 50, as 30? I can't hardly believe it. So he did this analysis, and he showed that the size predicts presence of obstruction, but if you take size together with flow rate, it predicts it even stronger. Now, this is something we are familiar with, right? I used that all my life in clinical practice. This is the old Abrams paper that says if your flow rate is under 10, there's a 90% chance you're obstructed. If it's over 15, it's a 30% chance to be obstructed. So all he does, he includes the prostate volume and demonstrate that prostate volume adds informational value to that and demonstrates the likelihood of being urodynamically obstructed. Good little point. I always, in my mind, consider prostate size when I look at the question, is he obstructed or not? And this just adds informational value to that. Now here's something that we all do. Andrea Tubaro from Rome asked this following question. What happens actually if we do a TERP and then the patient comes in and says, yeah, I'm not really perfect, and we give him an alpha blocker, or we give him a 5-ARI, or we give him an anticholinergic. In other words, the patient gets drug treatment after a TERP, after a green light laser, after a HoLEP, whatever it is that you do, because he's not totally satisfied. What happens actually to those patients? Well, they came up with a pretty low number of patients considering their ambitious project to look at patients treated in 2004-05 and followed to 2016. But I give him credit. If you look back in your database, patients you operated 12 years ago, you may not find many for follow-up. So he found 92, and some of them were retreated, and this is the difference. The patients who never received drug treatment after their surgery had a very low rate of a secondary procedure, but the patients who were not happy, they had a 40-45% chance of having a second surgical procedure. Good point. I'm thinking it's not totally innocuous, right? If you do a TERP and you did a good job, patient comes back and he says, yeah, I'm still getting up, I'm still having this. You say, well, take this drug, take that drug. It's not good. It predicts that the patient is not fully resolved. And many of these patients, in his series, 40% had a second procedure. It's a very high proportion, I would say, 40%, nearly, it's actually a little bit more than 40% that had a secondary procedure. So this is an interesting insight, in my opinion, what it means if dissatisfied patients go on drug treatment. In this session, there were 3 abstracts presented on nocturia and the relationship between sleep disorder, LUTS, and nocturia. One was from the NHANES study. This is a National Health and Nutrition Examination Survey. And this is a very, very big study, and it looks at men 18 to 70 years old, and it asks the question here, in the relationship between sleep disorders and lower urinary tract symptoms. These are men with sleep disorders, these are men with no sleep disorders, and what they showed is that men with sleep disorders had more often nocturia. These men had more risk of lower urinary tract symptoms, and men with obstructed sleep apnea were more likely to report lower urinary tract symptoms. You can see the age difference here, and you can see the comorbidity indices being higher in the patient with sleep disorders. So clearly there's a two-way street between sleep disorders and LUTS, and the question is sort of the chicken and the egg, which comes first? Sleep disorder leading to LUTS, or LUTS leading to sleep disorder, and so forth and so on. So the result shows that older age, Caucasian race, obesity, BMI, and higher comorbidity indices are associated with an increased risk of lower urinary tract symptoms in men with sleep disorders. So that's pretty much motherhood and apple pie. We would expected that. A Christian, Stephen Friedland, who is now at Cedar Sinai in Los Angeles, he was at Duke, he has access to the REDUCE database, and he has extensively examined the REDUCE database for additional data beyond that prostate cancer prevention indication. And here's a question he asked about nocturia. And specifically in the REDUCE data, there was a questionnaire administered. It's called the MOS questionnaire. It's a sleep questionnaire. So in the REDUCE trial, keep in mind this is a prostate cancer prevention trial, dutasteride resulted in improvement in symptoms, and specifically it improved nocturia episodes with a high p-value. Now that you heard my first talk about p-values, I assure you the p-value is very low here, not because the effect size is so great, but because the patient numbers are so high. It's 4,000 patients, remember, in the REDUCE trial. That's why the p-value shows so many zeros here, not because it was a great effect. But treatment with dutasteride had no effect on sleep function based on this MOS questionnaire, nor any specific domains of sleep, including feeling rested, getting enough sleep, etc., etc. This is the same when you focus on asymptomatic men or symptomatic men. Keep in mind, again, REDUCE is the prostate cancer prevention trial. It's not a BPH trial. So asymptomatic and symptomatic men, there was no big difference. So it's interesting to note that we focus a lot on nocturia when we treat LUTS and BPH. There's a lot written about it, a lot talked about it, and we worry a lot about it. But nocturia is only one part of sleep disorders. And in this study, the MOS questionnaire was fundamentally unaffected for men taken for a 4-year period to finasteride, even though if nocturia episodes were reduced. So I find that interesting. In the same reduced trial, with Friedland and his colleagues, we ask again a different question, namely, are sleep problems, this MOS questionnaire, sleep problems, are they associated with an increased risk of developing BPH or LUTS, defined by a symptom score overall of greater than 12 points, or 8 points, I'm sorry, more than minimal symptoms. And indeed, that's the case. Worse sleep course predicted the risk of progression, and asymptomatic men, again, keep in mind, that's a prostate cancer prevention trial. People didn't have symptoms beforehand. Worse sleep course by the MOS score predicted the development of BPH. So 3 abstract in this epidemiology section looking at, in large data sets, at sleep disorders, BPH, and LUTS and nocturia, and again shed light on this two-way relationship between sleep disorders and BPH. Here's some good evidence that men with sleep disorders are more likely to develop BPH and LUTS. In the NHANES study, there was evidence that sleep disorders were more common in certain men with BPH, the men with higher BMI, comorbidity indices, etc. Not something we can immediately, focus treatment on, but something makes us aware of the relationship between those two entities. Let's look for a moment at what was presented in the medical therapy section of the AUA for BPH. In general, there's not a new molecule out there, new molecules out there. So a lot of work is done on older molecules, and the PDE5 inhibitor tadalafil is oftentimes looked at. So here's a study from Japan where 60 patients were treated, and these patients were given tadalafil, and they were given the symptom scores, and they also had urodynamics. I draw your attention to the fact that the bladder outlet obstruction index dropped from 61 to 47, and this is presumed to be statistically significant, and there's a flow rate improvement, etc. And I say, whoa, this is interesting, because hadn't we always believed PDE5 inhibitors don't affect urodynamics? And in fact, here is one way I would urge some caution. The best trial, hands down, ever done in the space of a randomized controlled medical treatment trial in urodynamics with a drug was this trial. It was published in 2010 in the Journal of Urology by Domoshovsky. It was sponsored by Lilly. It compared 20 milligrams of tadalafil daily for 12 weeks with placebo. And the patients all had invasive urodynamics, and there were 200 patients. And that study was absolutely amazing. And I'm going to address one of the questions you asked. That study had not a single p-value. The study was published on the strengths of being an extraordinary, well-executed scientific trial with no p-value, but it showed the feasibility of doing multi-center and invasive urodynamic testing in multiple centers, and it showed shockingly that no parameter, peak flow rate, residual urine capacity, voiding efficiency, PDET at Qmax, bladder outlet obstruction, was statistically significantly different between placebo and tadalafil 20 milligrams. No parameter. So I operate on the assumption that anytime I see an abstract looking at this, I discard it. This is the best ever study done. PDE5 inhibitors do not affect urodynamic parameters. This is 20 milligrams daily for 12 weeks. And it's amazing that the drugs work on the symptoms, do not work on obstruction. Here's a paper that looks at a combination of tadalafil and tamsulosin from Korea. This is not new. They looked at a 12-week study and treated patients with it and demonstrated an improvement in symptoms, but only in terms of some symptoms and sexual function. I don't know what's true or not true. I don't prescribe PDE5 inhibitors with alpha blockers very much. I don't believe in the combination. But when looking at this Korean abstract, my mind went back to the meta-analysis done and the summary of what was known in the field. And what's known in the field is if you combine an alpha blocker with tadalafil, once daily, you have a small incremental benefit in symptom score and a small incremental benefit in flow rate, but in this meta-analysis, it moved the needle a little bit, and it proved to be significant. So you may do it, you may not do it. I think it's pretty costly, and it adds possible side effects. I think personally the benefit is marginal, but it is something that has been proven to be beneficial. The Korean authors argue that tadalafil compensates for the sexual performance, which is a side effect of tamsulosin. I disagree with that totally. The only sexual side effect of tamsulosin is anejaculation, and tadalafil doesn't help that. That's just simply not true. Tadalafil enhances sexual performance, but not the ejaculation. Tamsulosin blocks the ejaculation by alpha-1A blockade, and this has nothing to do with the side effect of tamsulosin. Now here's a paper from Nagano in Japan, where they gave tadalafil 5 milligram for men with LUTs, and they demonstrated that there was a decrease in a parameter that is a measure of blood vessel hardness, so a measure of atherosclerosis. And you can see that this measure, the brachial arterial P index, decreases after 3, 6, and 12 months. And they say that tadalafil improves these data, meaning the vessels have more elasticity, and this is a beneficial effect overall. This is not the first time, right? You've seen this before. There have been abstracts like this before. And actually, it's not new. I show you now a paper from 2014, which is an analysis of all randomized tadalafil trial, asking the question, is PD5 inhibition a good thing for aging men? Is it cardioprotective? And so it's quite amazing. This paper was published in BMC Medicine. Urologists probably don't read it much. And it showed that globally speaking, the cardiac index was improved in these studies, and the ejection fraction was improved. And in this study, Janetta et al. Found that there is a remodeling effect. It reduces cardiac mass in patients with left ventricular hypertrophy. It improves cardiac performance. It improves specifically the cardiac index and the ejection fraction. There's no change in afterload. There's an improvement in vasodilation, and they claim that this anti-remodeling property improves cardiac inotropism independent of afterload changes with a good safety profile. So many people have argued this, right? They have said that, well, a tadalafil a day is maybe good for erections, maybe good for the prostate, it's good for overall health, and it's cardioprotective. Eli Lilly or Pfizer or any of those companies never wanted to embark on a study that they would happily do for Lipitor or a statin drug, namely enrolling thousands of men in a long-term trial to see if these drugs truly have a beneficial cardiovascular effect. But I will say that many serious researchers are of the opinion that tadalafil may have a beneficial effect on the vascular system, cardiovascular system. It's just that nobody ever has done the trial. And while those companies spend mega millions on statins in this capacity, nobody spends the money on this. So I just draw your attention to that. Also in the section on medical management, there was a Cochrane analysis presented on desmopressin. As you know, desmopressin, with its antidiuretic effect, is one of the few drugs that actually shows an effect on nocturia. And this meta-analysis comes off the Timothy Wiltshop at the Minneapolis VA. This is a Center for Cochrane Meta-Analysis. They do technically a good job. And it shows you how poor we do on nocturia. This is the outcome of desmopressin versus placebo, number of nocturnal voids. So there's 1.41 fewer, and in the placebo group it's 0.86 fewer. So the placebo effect, right? The regression to the mean. If you enroll patients who pee 4 times at night, by regression to the mean, you will reduce that. So the regression to the mean effect is in that placebo effect of 0.86. And desmopressin reduces 1.5 episodes per night. Maybe it's a good thing to remember that. 1.5 episodes. That's what you can achieve with desmopressin based on the world literature. It's not all that dramatic, I would say. 5 ARIs have been in the line of fire for ED and specifically sexual dysfunction that lasts, that doesn't go away, right? It seems like there is this propecia help group online, and they talk about the lasting sexual side effects. So Curtis Nickel looked at a very, very large database, 72,000 men over a 20-year period, and asked the question, is drug treatment for latent BPH associated with first new reported ED? Well, let's look at this. So this is a cohort study in these 72,000 men, and this is the incidence rate, and this is the adjusted incidence rate per 1,000 patients. Alpha blocker is set to 1, 5-ARI is 0.92, combination is 1.09. In this large cohort, no difference in spontaneously reported new onset ED between any of the treatment groups, alpha blockers versus 5-ARI versus combination. This remained so regardless of the number of prescription or the timing of use in this case control nested study. And when they looked at duration of treatment, you can see that after 5 years, the risk of patients reporting ED increases from 1 to 2.8 in the alpha blocker group, and in the 5-ARI group, and in the combination group. So it is what I have oftentimes said and speculated, that the incidence of ED and the treatment with 5-ARIs in combination therapy is oftentimes a phenomenon that we see in the aging men. The older they get, the more ED they have, and the longer they take it, the older they get, the more often they develop ED. So this is a very large data set. It's dirty, it's a administrative data set, but it's an interesting contribution to the literature. They didn't see any evidence for that. Now, there was a session on basic research. 20 posters were presented, and I know this is kind of a little bit boring. I'll just give you a little bit of an idea as to what people are thinking, what people are doing. Stefan Uckert and Peter Hedlund, these are two people who are very active in the research in PDE5 inhibitors, and specifically the PDE5 in the human prostate. And they demonstrated here that the PDE5 controls the transition zone of the prostate, and so gives credence to the idea of using PDE5 inhibitors in BPH. I'm not going to dwell on that. This is a paper from China. They look at smooth muscle myosin and non-muscle myosin isoforms in the prostate, and I'm not going to go into the details, only to tell you that the idea here is that if you focus on the isoforms of the myosin, the smooth muscle myosin and the non-muscle myosin, you may identify different targets, not just alpha blocker or PDE5 inhibitors, different targets for treatment. There's a group of researchers in Portugal, in Lisbon, and they publish regularly on BPH, clinically and basic research, and they have an idea that serotonin or 5-hydroxytryptamine is an important part of BPH. I developed this for you here. So they showed that this is produced by neuroendocrine prostate cells, and they show that in BPH these cells are decreased, and they show that it inhibits non-malignant prostate growth. And here in this poster they demonstrated that if you block that you actually make the prostate grow substantially larger. So 5-hydroxytryptamine or serotonin depletion induces BPH group, and they say this is an androgen receptor upregulation. And so they feel that this serotonin system, the 5-hydroxytryptamine system, is a potential target for therapeutic intervention. This is completely untapped. No company has ever looked at this, and this is a completely novel idea as to medical treatment for BPH. Now, this is another serious group of researchers at the Mass General. They're funded by the NIH, the DoD. They have a lot of basic research funding and a lot of firepower. They are excellent basic researcher, and they have asked the question for many years now about the group of men that has 5-hour reductase resistance. They are resistant to treatment with 5-hour reductase inhibitors, and they have shown that the expression of the 5-hour reductase type 2 changes in patients, and if they have a underexpression, they are non-respondent to 5-ARI treatment. And here they show that the absence of steroid 5-hour reductase type 2, androgenic pathways are blocked, there's no DHT, right? alternate pathways are upregulated. And what they show here in this graph is, while in those men the steroid 5-reductase type 2 is downregulated, what's upregulated is estrogen receptor alpha and a variety of other things. But mostly it's an upregulation of the estrogen pathway. I bring this to your attention because you may be aware that different companies and investigators have looked at the estrogen and progesterone receptors in the prostate as potential therapeutic targets. Lilly actually at one time had an estrogen receptor beta agonist tested for BPH. It failed, but still this field is open, and there's a potential that a combination of something like a 5-ARI and an estrogen receptor agonist might be a beneficial treatment. So this is a very believable and very hardcore group of basic scientists, and those data, in my opinion, are good data, and it's worth following that. Good. Now, just a few things on surgical treatments, few things because I give a talk a little later on minimal invasive treatments. This is interesting to me. I do a lot of green light laser, and Kevin Zorn and others got together and they asked the question about learning curves. And it's interesting, when you look at the learning curves in 3 centers, in Montreal, where Kevin Zorn is, in Paris, and in Toulouse, they show the vaporization time over operative time. To me, this is a hallmark of an efficient surgeon, because my residents, they are on the pedal, off the pedal, on the pedal, off the pedal, and so the vaporization time over operative time is 25-30%. And you can see that it took these 3 centers 100 to 150 cases to get to a vaporization time over operative time that is in the 60-70% range, and to get to 75%, it took them 150 cases. Surprising to me. But I see it in our own residents. They're very hesitant. They come off the foot pedal, they push the foot pedal, they look, they study. While I myself, I'm on the foot pedal, I know where I'm going, I know where my next move is. But all these centers showed an increase, and it took 100 cases to get to that level of efficiency. Very important insight, in my opinion, because it's not as easy to do the green light laser well as some people think. This is the energy volume ratio. This is the energy administered per gram of tissue. And that's shocking to me, that between the 3 centers, 1, 2, and 3, there are such differences. It ranges from 5,000 joules down to 2,000 joules per gram. Let me translate. If you have a 50-gram prostate, in one center, they would give 250,000 joules. In another center, only 100,000 joules for the same size prostate. This is shocking to me, because there must be the right amount of energy per gram. And I always feel that if I administer under 200,000 joules, I'm not doing a very good job. But so it shows that even in these centers of excellence, there are great disparities. There were a handful of abstracts presented on bipolar plasma vaporization. This is also known as the button TURP. And it's interesting, it seems to gain a foothold both in Europe and in America. Certainly in Germany, it's popular there. This is a German paper. They show that over a 5-year study, it showed a good volume reduction and a good improvement in symptom score, as well as in flow rate improvement and PSA reduction. So I don't use it much, but this button TURP is very popular, and it lives up to its expectation. This is a comparison, and it's also from Europe, and it compares the 180 watts green light laser with the bipolar vaporization, and it shows very comparable symptom score changes. These are the 2 groups. You can see the symptom score changes. These are the flow rate changes. And the first group is the green light laser, the second is the bipolar, and you can see that both have an equal improvement and an equal improvement in the prostate volume as well. Oh, and not dwell on that. This is a paper from Syracuse. They asked the question what to do with patients who have the TrueSOR underactivity, which is a dilemma, right? If you know a patient has the TrueSOR underactivity, you're supposed to tell the patient, well, if I do a TURP on you, a HoLEP or a green light laser, it may not help you. And the patient may say, so what are you going to do? And you say, well, I'll give you a catheter, and you catheterize yourself. And the patient say, really? That's it? And so they set out and they said, well, what happens if you take patients with documented obstruction, defined here, very classic, BOI of 40, versus patients with diffuse or underactivity, very classically defined. And they show that the patient with diffuse or underactivity also recovered. Most of them resumed spontaneous voiding, and the symptom score improvement was not unreasonable. I suggest to you that diffuse or underactivity, 20% of our patients have that. It's a difficult topic. I myself oftentimes follow the same principle. I basically tell the patients, look, I'm going to do a surgery. I may even put a suprapubic tube in so we can monitor your residual urine and we'll see how you'll do over time. Now this is a paper here, and I don't advocate this. Those folks took prostates over 200 grams and treated it with a 180 gram laser, 40 men. This falls in the category, okay, so here we treated 40 patients and here are results type of paper. I don't think this will make it into the Journal of Urology. So they treated these patients and they said, look, they did good too. Yes, it took us a little longer, but they did okay. Their OR time was longer, and they had a lesser improvement in symptom score and flow rate, but they did okay in the end with that green light laser. And I myself would say to you, why would I do that? I think that the larger prostates we have learned are either treated well by the whole lab procedure, by the thulium enucleation procedures, or the transurethral enucleations, or by open procedures or simple prostatectomies. And I will conclude my overview of the AUA here by making a pitch for what I currently do a lot, namely robotic simple prostatectomies. The robotic simple prostatectomy is a natural extension of a radical prostatectomy done robotically, and our residents are very good at that. So open prostatectomy have a pretty good transfusion rate and a fairly long hospital stay, at least in Europe. But the robotic simple prostatectomy have a very short hospital stay and a lower transfusion rate. Pressure in the abdomen is high, so there's less bleeding, obviously. And it's easier to adjust to it than the whole lab. I think that's the crucial question. The whole lab requires a learning curve of 40 to 60 cases, and there's few centers of excellence, but there's many urologists who can do a very good robotic prostatectomy, and so it's a natural transition. We had done, by the time of this analysis, just 100, and I compared it with 100 of my own simple open prostatectomies that I've done before, and I found that actually the outcomes were quite good. Substantial improvement in symptom score, substantial improvement in flow rate, and I believe that the simple robotic prostatectomy is something that I can teach easily to our residents and communicate to them, and they can leave the training program and do it as one option to deal with very large prostates. So when I showed you at the beginning what was presented at the AUA, I will close out with a few observations. There is some basic research in BPH, less than in cancer and other diseases, despite the disease being very population prevalent and despite its very large human and economic cost. But there are some insights in these basic research papers I try to share with you. There are some epidemiological insights. We talked about the post-procedural retention, how it predicts BPH procedures, the therapies that take place after a TURP out of frustration leading to secondary procedures. We talked about the epidemiological data on sleep disorders, nocturia, and LUTs. Some of this proves to be useful. There's no new molecule right now. There are some targets, maybe the serotonin system, maybe estrogen progesterone receptors or agonist or antagonist. But there's a lot that is said about PDE5 inhibitors, and I didn't talk about the anticholinergics and everything very much, side effects of drugs, and I try to share that with you. I will discuss the minimally invasive surgical options with you a little later in the morning, and there's a host of things presented, as you know, every year in the surgical arena, whether it's the whole lab or the thulium or the electrovaporization, the green light laser, and now also the simple prostatectomy by robotic approach. So I was pleased to review this with you, and I certainly hope that some of you will come to San Francisco next year, where the AUA is going to be held in the coming year. If there's any questions, I'll try to answer it. I attended most of the BPH sessions, so I know pretty well my way around it. And if to this particular topic there's a question, I'll be happy to address it.
I think for time's sake, we'll carry on with your talks, and then we'll leave the questions until the end.
Good. I will now naturally launch into a discussion on the minimally invasive surgical approaches for the treatment of BPH. And as far as I'm concerned, this was sort of a banner year for these minimally invasive treatments at the AUA, no question about it. And I was very much involved in that. So I talked to you a little bit about the treatments that are currently approved, being evaluated, or being standardized by now, and the ones that are still in the works. There's a lot of excitement around this because we urologists love toys. We love to work with new technology, and it's sort of what we have done all along. The first I want to share with you is a company that makes a device from Israel called Meditate. It's an implantable nitinol device. It's a spiral that is inserted, as you can see here, into the urethra. It's left in for a few days, then removed. It makes these grooves in the urethra and the prostate. And the company claims when you do that and you remove it afterwards, you have enough of an opening to induce a lasting symptom improvement. And they make the argument that they demonstrated a substantial symptom score improvement out to half a year and a substantial flow rate improvement out to half a year in a study from Turin that they published. They're currently doing a US trial. I have my doubts, and my doubts are obviously from the observation that balloon dilation for an hour or 30 minutes or 5 minutes wasn't really terribly effective in the long term. And this leaves, the device stays in for 5 to 7 days, and I don't know how effective it will be. But it's a trial that is going on in the United States right now. This is a fellow by the name of Nick Damiano. He comes from Stanford. He had an idea and called his company ZenFlow. Sounds pretty good, ZenFlow. And he has this idea to insert also a spiral made of metal into the urethra, but it will be done with a flexible cystoscope. As you know, most of the minimally invasive treatments require still a rigid scope, and this is a flexible scope, so it's a bit of an advantage in the outpatient setting. This device is implanted, and he has done animal experiments to show it's tolerated and it is overgrown by epithelium, and it's covered very nicely. He has also done some cadaver studies for feasibility, demonstrating feasibility, and he has done some clinical studies in Romania, in Central Europe, and he demonstrated a symptom score improvement, as you can see here, out to 1 year. He's very ambitious. He's wanting to launch a US trial. About a month ago, I was on a conference call with Nick Damiano and his company and the FDA. The FDA has a lot of concerns about the device because it stays in, and they want to be sure it doesn't encrust and cause problems like the Urolume stent. But he wants to do a US study, and he already wants to start a study in Australia, New Zealand, and Europe, as well as this multi-center, 20-site US study, which will be the pivotal study. A company called ZenFlow, so you have to stay oriented. This will be coming up relatively soon, this trial. For the first time, the aquablation was presented at the AUA, and this dates back 7 or 8 years that I met first with Nikolai Ayuri, the engineer who founded this company called Procept Biorobotics. This is a device that is a bit more complex, definitely done in the OR, and it aims to replace a TURP by a robotic water TURP. It actually uses the power of water administered through a handpiece coming out of the tip here, like a water pick almost, and the stream of the water has a very high pressure. It's like a water pick that is used to clean industrial things, or you clean your driveway, clean wooden decks and whatnot, with a very high water pressure, and it basically obliterates the prostate tissue. So the company is claiming that this treatment is humanly planned. The surgeon does ultrasound and cystoscopy and plans exactly the prostate outline and plans the treatment area And you can see these various steps of the treatment planning. And once the treatment planning is done, the treatment is automated and it proceeds robotically, if you will. So the data that were presented were the TURP versus aquablation trial, a non-inferiority trial, in typical men with BPH and LUTS. In fact, many men had a intravesical component or middle lobe, and that's one of the strengths. You can treat that. These were prostates of 50 to 55 grams. And the study was designed as a non-inferiority study with a superiority in terms of adverse events. The goal was to show it is safer than a TURP. And in fact, if you looked at all adverse events, it's a primary safety endpoint, it was 25% versus 40, and that proved to be superior. And then they had a second endpoint looking at Clavian Dindo type 1, mostly sexual-related adverse events, and it was also superior in regards to that secondary endpoint. So it cleared the hurdle of being, quote, safer than a TURP. Then when we looked at, and safer comes along with better ejaculatory function. So the TURP has a decrease in ejaculatory function, but this has an improvement in ejaculatory function, or at least it stays the same, so it's better than the TURP. But what was surprising was that in regards to symptom score improvement, it proved to be not only non-inferior, but actually numerically a little bit better. Blue is aquablation, red is TURP. This is a fairly sizable reduction from 23 to 6 points at 6 months, and it's the same as in a TURP. Similarly, flow rate improvement a little better numerically, and when you look at prostates 50 grams or larger as a subgroup, actually the safety profile looked even better in favor of aquablation. Fewer adverse events in the larger prostates compared to the TURP. And in these larger prostates, over 50 grams, the IPSS score improvement was greater in the aquablation group and less in the TURP. That's interesting, right? In those larger prostates, those 20 surgeons in 20 international centers did a less good job than the robotic ablation. The robot doesn't care, it just ablates the tissue. We care. We see a big prostate, we may be a little hesitant, a little reluctant, so our surgical efficiency with a TURP in bigger prostates is seemingly less, and we're less good at it maybe than the robot, because the robot does it automatically. And interestingly enough, if you look at the time point of treatment, the duration of the actual ablation is size independent. So whether the prostate is 30 grams or 80 grams, it takes always 2 to 3 minutes. And of course with the TURP, the resection time increases with time. So is this the gold standard, the platinum standard, going to replace the TURP? Not quite yet. These are just 3 and 6 months data, so there is a long haul until we have 1 year data or long-term data. Plus, it's quite a get-up to do this treatment in the OR. But it's very interesting, and it appeals to us urologists because we plan the treatment and it's robotically executed. So it's kind of a neat way of using a technology that is non-heat based. May I say that Nikolai Alyuri, the engineer, built this on the concept of the power of water and avoiding any heat in the prostate, which some of you may believe, and I think it's reasonable. Heat and thermal energy is damaging. It is the thing that causes irritative symptoms, causes storage symptoms, causes coagulation on the surface, may even cause erection or ejaculatory problems. So by avoiding any coagulation and any thermal effect, maybe that is why the treatment is safer, quote unquote, and maybe that's where it will find its role. It will remain to be seen. The Rhizome system, and I don't know if this is widely available in other parts of the world really, but it's certainly available in Europe and the United States. It is a treatment that is based on the power of steam. So water is heated to vapor by heating it with radio frequency energy. And when you do that, you put a lot of energy in the water and the steam holds that energy. Just to give you an example, if you heat 1 liter of water by 1 degree centigrade, that's 1 kilocalorie of energy. It's a definition of what a kilocalorie is actually. So if you heat a liter of water from room temperature, 20 degrees, to 100 degrees to vapor, it's 80 kilocalories. If you put that steam into the prostate or into the body, it will decrease in temperature to 37 body temperature. So it will give off 63 kilocalories of energy, right? Because it will cool down. So this treatment works entirely on that phase transition from steam injected into the prostate back to water. And so it's currently indicated for men over the age of 50, prostate 30 to 80 grams, including men with a middle lobe. And it's done by injecting the steam through a rigid cystoscope, specially made, through a needle into various portions into the prostate. And when the steam is injected, as this little cartoon shows, the steam is condenses immediately, gets back phase change to water. It gives off the energy in the process, and specifically it's about a half a cc that is each time administered, and it gives off 200 calories, and it reduces, it basically kills the cells by denaturing the membrane. So it's a sound principle as far as I can tell, and they did a randomized sham-controlled trial. 200 patients enrolled, and what the trial showed was after 2 years, a substantial improvement in symptom score and a substantial improvement in the peak urinary flow rate, as you see here. Now, this treatment can also be administered to the middle lobe, and actually it makes a difference. If you turn the needle down into the middle lobe, you induce a better effect on the flow rate. When the median lobe is present and is treated, as shown in blue, the flow rate improvement is 6.5, and if you don't treat it, it is only 2.8. So the treatment is amenable for intravesical lobe, median lobe treatment, and it is recommended to treat the median lobe. They did also a crossover study, i.e. the sham-treated patients were given the real treatments, and during the sham period, they had a marginal placebo effect, sham effect, regression to the mean effect, but the real treatment induced a decrease from 20 to 10 points and a flow rate improvement from 10 to 16. So it proved to be successful. We treated in a clinical series about 125 patients, and we found very similar results. Symptom score improvement, both irritative and obstructive, flow rate improvement from 10 to about 17, and most of the patients were satisfied. And this is actually a clinical cohort. It's not a randomized series. There are no enrollment criteria, so the regression to the mean effect is not existent here. And this effect on symptoms here and on flow rate is independent on prostate size between the ranges of 30 and slightly above 80, independent of size, because you inject more steam into the larger prostate. So this is a reasonable treatment currently available in the United States. One drawback, it's quite evident, patients will require a catheterization or a temporary stent. A spanner stent can be used or Foley, but it has to be in for 3 to 7 days. But other than that, it's attractive, particularly for median lobes, and the data extend to 2 years now. The next treatment is a UroLift treatment, and I used this little cartoon to show that the UroLift treatment aims to open the prostate urethra like a theater curtain, and you're very well familiar with how that is supposed to work. When I first was introduced to this technology by Ted Lamson, the head engineer behind it, I said, Ted, don't put metallic things in the urethra because the FDA will not like you for it. They think of the advertisements by AMS with the UroLume stent and how wonderful it looked, and the reality that we saw as urologists with the UroLume stent where there were incrustations and we had to get the thing out and pull out the wires and so forth. And he said, well, this is not quite the same. He said, there's very little exposure inside the urethra and no exposure in the bladder, and it's basically this implant consisting of an outer anchor, a suture, and then the inner tab, which is stainless steel. It's very small, not the only thing exposed, and it will be eventually overgrown. As you know, it's basically applied also through a rigid cystoscope, and it's a little bit of the art of doing it that you exert compression to the lateral lobe of the prostate. When the outer anchor is fired, you exert compression just as much as you think you need to keep it open. Then you fire, cut the suture, the tab holds it in place, and you can go from an appearance like this to an appearance like this in an ideal case. So the big clinical trial that was done was the LIFT trial in the United States. It was a 2-to-1 randomized FDA trial. And the reason it's worthwhile mentioning it at this meeting and in this context is because at this year's AUA in Boston, the 5-year data were presented. This officially ends the trial. And by the way, they also published at this point the 5-year data in the Canadian Journal. And the data, the study is completed for the FDA. So these were men 30 to 80 gram prostates, but they could not have a median lobe. The company is working on a technique to treat median lobe, but this trial did not treat median lobe. They were average size prostates, 44 grams, peak flow rate around 8 ml per second. And all treatments were done under local except one single treatment. And most of the patients went home without a catheter. Some had a catheter between 1 and 7 days. Currently, I would say the odds of requiring a catheter in my practice is about 1 out of 4. So 1 patient gets a catheter and 3 patients go home without a catheter. And if they have a catheter, I leave it in for a couple of days. The study was blinded, and effectively so. The patients didn't know what they had done at the time of treatment, and even at 2 weeks, but at 3 months, they understood they either did or did not have the treatment based on their therapeutic response, which is good to know that the blinding essentially worked. The issue with the incrustation for the FDA is very important. If the anchor, the outer anchor, ends by accident inside the bladder, the patients will form incrustations, and incrustations were seen in 2.1% of the implants. They all have to be removed, and this is one of the risks. And it's therefore important to pull back 1.5 centimeter and then throw out the anchor so that it ends up in the capsule here. If you start here and you bend it too lateral, the anchor could end up in the bladder. It's a very bad scenario when that happens. So this is one big technical aspect, to drop back and not to be too close to the bladder neck with this treatment. The 5-year data was available on 74% of the treated patients. That's for 5 years not so bad. It's a 25% loss of patients. And of those patients, 13.6% required a retreatment. So it's 2 to 3% per year retreatment rates. After 5 years, there was a good improvement in symptoms, in quality of life, in BPH impact index, and in urinary flow rate, although there was some attenuation over time in the flow rate improvement. But this treatment, and you may know this and heard of this treatment leaves the bladder neck intact, ejaculation and ejaculation bother is unchanged. Shim score is unchanged. So this is what draws patients, the younger crowd, in to seek this treatment because they maintain ejaculatory function. So many patients come to me and say, I want this because of the ejaculation function. The LIFT study also did a crossover trial, and the patients who received initially sham treatment had a very marginal effect, but when they were crossed over in yellow, they had the same effect that the original treatment group had, which is what we would expect. So in Europe, they did a trial comparing it directly to TURP. This was a 2-year trial. They called it the BPH6 trial. They called it BPH6 trial because they had a endpoint, it's a composite endpoint out of 6 things. You had to have a symptom score improvement, you had to maintain sexual function, ejaculatory function, you had to recover in 4 weeks, no clavia and dindo complication was allowed, and no incontinence. And so this was a composite endpoint trying to showcase the good features of the UroLift against the TURP. The symptom score improvement was not as good as the TURP, that's expected, but the quality of life improvement was similar. There was a quicker recovery to normal activity with the UroLift compared to the TURP. I would expect it. I tell my patient they can go back to work a couple of days later, and the TURP, I tell them you can go back 10 to 14 days later. Erection function was maintained in both groups, no problem there, but ejaculatory function, a big difference, just like in the water ablation treatment, a decrease in the TURP and maintenance in the UroLift group. Ejaculatory function is sort of the battleground of these treatments nowadays. Overall, the same number of patients in both groups had some sort of retreatment in that European BPH6 trial. And when you looked at the composite endpoint, more patients in the lift group than in the TURP group achieved that composite endpoint, significantly so. But of course, that's different what you look at. If you look at flow rate, well, in terms of flow rate, the TURP is superior, as well as the raw symptom score. Some tips and tricks. This is not a good patient for a urolift. There's no lateral lobe enlargement. There's a high bladder neck. I would do an incision. I think the urolift is not suitable. This is not a suitable patient for the urolift. This is a ball valving median lobe. I wouldn't even dare try it if I see that by flexible scope. This is a good patient for the urolift. Mostly lateral lobes. They meet in the midline. They're visually obstructing, and they can be effectively treated, and you can achieve this result shown in a cartoon here and shown in real life here. This is a patient I did last month. Before treatment, lateral lobes, and after treatment, there is a clip, there is a clip. This is the view of the prostatic urethra afterwards. This patient had a very good success. Here's a patient with a slightly larger prostate, lateral lobes before, and after you see one clip here, and the widening of the prostatic urethra. There's an increasing concern in terms of MRI compatibility, and I want to make a final comment on that. The urolift is compatible with a magnetic field strength of 3 Tesla of an MRI. You have almost no temperature increase, even if you spin the patient in the MRI for like 20 minutes. It's 2.5 degrees centigrade after 15 minutes. And the devices are highly visible. This is a clip, this is a clip, these are clips, and you can see these clips on the MRI, and they're clearly visible. In fact, they cause an artifact, and the artifact can interfere with an endorectal coil MRI or an abdominal MRI for prostate cancer detection. This can be a problem, just like a hip implant can be a problem. In our institution, the radiologists are working on developing softwares to eliminate that, and they are very successful. Here is a conventional ADC run on an MRI in a patient with a hip implant, and you can't see nothing. There's nothing visible right here, but they do some kind of technical trick to it, and they make it look like normal and identify this cancer lesion right there. This here is a patient who has a hip implant right here, and he has urolift clips, and he has artifacts. And here are the artifacts. And here is the run with the adjusted software, and you can clearly see the prostate just like as if they didn't have an implant. So it's possible to do it, and hopefully these software modifications will eventually be widely available. The company is trying to modify the device. Instead of having a one-time use cartridge, they have a system where there is one sort of part of the cartridge, and you just attach a new clip. And so instead of having to throw away all these things, you have just one device, if you will, and the cartridge is for the individual clips, as many you need. So this will come in 2018 as a slight improvement. So whether or not any of these treatments are there as far as the gold standard is concerned, it is quite clear that Rhizome is there for 2 years, is fairly standardized, reproducible. The lift procedure is there for 5 years. Some of the others are highly experimental and haven't reached many of these criteria for what it means to be a gold standard. So this is my last slide on the update on minimally invasive surgical options for BPH from the AUA. And again, I leave it to the moderators to determine whether we want to have any questions or have no questions at this time, or leave this to some endpoint. It is exactly 9:35, so I'm pretty good right now.
Okay, I might start myself actually. You show us so many techniques in your own practice. If you have a patient with that, what is the most common procedure you do for prostate operation?
At this point, I do equally common green light laser ablation and TURP, and I do monopolar and bipolar, just so that the residents learn it all. And I do approximately per year 80 of each. I do 50 at least robotic simple prostatectomies per year for prostates that are over 120 grams in size. And I do approximately 20 to 30 urolift procedures per year. And in our practice, we do approximately 60 rhizome procedures per year. And in addition, I participate in the Meditate trial and in the ZenFlow trial, and in the water ablation trial, and they're doing actually a new trial now. So I do about 50 research procedures also. So I myself may do 300 thumb BPH procedures, 160, 180 of those standard green light and rhizome, 50 a little bit more open, simple, robotic simples, and then the rest is these minimally invasives and research
So
procedures.
basically, TRP and the green laser are the most
That's
common.
correct. Out of everything that is commonly used out there, what I don't do, and I have a personal preference there, I don't do the button TURP. I don't like the idea to lay down this big surface of coagulation necrosis on the surface of the prostatic, inside of the prostatic fossa. I don't like it very much, and I've had patients who had sloughing of their tissue a few weeks later, so I stay away from that. And I do not use the HoLAP. This is a preference because the HoLAP is an excellent procedure, but it's very difficult for me. We have 4 residents a year. If I want my residents to learn a technique solidly, it is almost not possible. And as you know, that experts like Jim Lingeman and Mitch Humphreys and Amy Krambeck, they only have their fellow do it. So they don't have residents do it. So it's not something you can teach a resident in 15, 20 cases a year, go do it, right? So that's why I don't use it.
So I think.
Yeah, it just might be a very similar question. Like you have all of these procedures.
Yeah.
And you talk to the patient in the clinic. So how do you approach and how do you do this versus that?
Patients come to me just like they come to you. Some of them are very educated and some of them are very uneducated. They say, Doc, you do what you think is right. Patients come in and say, I want the lift procedure because my ejaculation, yada, yada. And so I examine him and I say, okay, you're a candidate, we can do it. Or I say to him, you're not a candidate. Your prostate is too small, too large, has an intervesical lobe, and then it's not possible. So every patient gets a symptom score, a SHIM score, gets a flow rate and PVR. And in deviation from standard guidelines, every patient gets an ultrasound. I know there's a bit of heresy because the old guidelines all say, imaging is, don't do imaging. But every patient gets an ultrasound in my practice because so much hinges on the size and the shape of the prostate, right? So everybody gets an ultrasound. So if it's a standard prostate and the patient doesn't have a preference and the prostate is, anything from 30 to 100 grams, I look at it and I do either a TURP or a green light laser. And honestly, much of it is decided by the patient's age and comorbidities and PSA issues. For example, let's say it's a 53-year-old man with a PSA, it's 5, and he had 1 biopsy, and I'm saying, darn it, but something is not right here. I do a TURP, I want to get that tissue. But if it's an 80-year-old patient, I do a green light laser. I don't care about the tissue so much. If the guy's on aspirin, I'll do a green light laser and I say, take your aspirin. I'm fine with aspirin. I'm even fine with Coumadin. But in a TURP, I wouldn't be fine with a Coumadin. So these are decision points. If the patient has a distinct interest in a minimally invasive treatment and has a median lobe, I would do a rhizome treatment if everything else fits. Then I could put the needle in there. If he does have no median lobe, he can choose. And if he wants the lift, I'll do the lift procedure. So it's an issue of patient's age, comorbidities, prostate size, and shape, where I try to fit everybody in. But since I have access to all these things, it's sort of my own judgment and imposed upon what the patient's wishes are. Patients have wishes, obviously.
Just to clarify, when you said every patient has imaging in terms of an ultrasound, you meant transrectal, correct?
Yeah.
Okay, so we'll carry on, and then if we have any more questions, we'll see if we have time at the end.
Sure. I just want to take 30 seconds and say that the AUA guidelines have always said imaging is optional and it's not important. And I want to just clearly state that I'm not following that principle. I think imaging is important. And if you ever visit an American setup, so in our clinic and in most setups, if you do an ultrasound imaging, you have to kind of arrange it. You tell the nurse, well, set up for an ultrasound imaging, and there's a procedure room, and you do the ultrasound and that kind of thing. So a year ago, I bought the smallest possible transrectal ultrasound unit, the cheapest one possible. It's like $15,000. It's like a little laptop computer with an ultrasound probe, and it's on a rolling cart. And I literally take it with me, and I do it because I want to prove a point that this ultrasound is just an extension of my examination. I take it into an exam room with me, and I do an ultrasound, and it's done in 3-4 minutes. And it's amazing. I have it Bluetooth connected, and it loads up the images to our electronic medical record. And so I make it part of my initial assessment. And I make it as an experiment for myself, because after a year or two, I want to see how often I use it and how it influences decision making. Good. For the next 20 minutes or so, I want to talk. These talks were, the sequence was given by the AUA. I might have done a little bit differently, but either way, it's fine. Talk a little bit about unresolved issues in LUTS and BPH, and what's still out there worth looking at and researching. And I think there are several. And one of the problems is, and it dovetails with what I just said. I just said I don't follow the guidelines in every respect, and I admit that. The problem with the guidelines is they're great in terms of giving some general guidance for the treatment of patients so that everybody can expect a reasonably similar evaluation and treatment around the world. But one of the problems is they always have the standardized patient, the index patient. Everything starts with that index patient. And patients are not all index patients. Some patients are different from the index patients, and not all the conditions that are listed there are part of the guidelines. So even if you apply the guidelines ideally, it doesn't always work, right? We know that with medical therapy, only 70% of patients respond to all our medical therapies. So part of the problem is there are issues in our patient that present where we don't have a perfect answer. If you have one, let me know, but I doubt we all know it. So there's this one issue of the intravesical protrusion I want to talk about today. The second issue of post-void residual. I've traveled around the world and I ask questions. What do you think is a safe and an unsafe residual urine? And the answer is dramatically different. Some people say anything goes, 300 cc's, 400 cc's is fine. Others say over 100, you've got to do a surgery. I said, why? Where's the data? So it's an unresolved issue. The TUSA underactivity is both unrecognized and difficult to diagnose, and then it's very difficult to make a meaningful treatment decision for it. But the problem is that we don't know it when we enter into a treatment with our patient. So it requires a lot of additional research. And then the whole field of nocturia, nocturnal polyuria, and I touched upon the frustrating experience with treatments, including the desmopressin I just mentioned a moment ago. Let me talk about intravesical protrusion or intravesical lobe or middle lobe or bowel valving lobe, and use that moment to give credit to Dr. Fu from Singapore General Hospital. He's a very nice man. He's now retired, but he worked at the Singapore General Hospital, and he single-handedly, in my opinion, drew our attention to this problem more and more over time, and I will visit that with you. So the intravesical protrusion, in my opinion, is a very important thing to identify early on so you know you're on the right treatment path, the right algorithm. It is the protrusion of the prostate, as you well know, from this potential line of bladder neck, the baseline, and this is the distance that is measured. These are different examples showing it here. And Dr. Fu originally proposed 5 millimeters, 5 to 10, and greater than 10 millimeter. And for all I know, that's pretty good, actually. Those are pretty good boundaries and grades of the intravesical protrusion of the prostate into the bladder. He himself published already in 2003 that it correlates with obstruction. So, for example, if you have grade 1 and 2, 70% of men are unobstructed, and those with a peak flow of 10 and a low residual, nearly 95% are unobstructed. So if you have a pretty good flow rate and you don't have a substantial intravesical protrusion, obstruction is very rare. On the other hand side, if it's a grade 3 obstruction, greater than 10 millimeter, Most all are obstructed except those with an excellent flow rate and with no residual urine. The data are shown here. So it correlates with baseline obstruction measured by invasive urodynamics. Remember, I showed you the slide from the AUA about this parameter with prostate volume and flow rate. Well, Dr. Fu uses the IPP and comes to a very similar conclusion. This shows the fact that alpha blocker response is dependent on the degree of the intravesical protrusion. This is a Korean paper. It's not Dr. Fu's paper, but it's from Korea. It shows the intravesical protrusion on average 0.9, 6.9, and 16.6 millimeters in grades 1, 2, and 3. And here it shows that those three groups have a vastly different response in terms of symptoms with an alpha blocker, namely ranging from 8 points to 6 points to only 3 points. So the highest IPP respond poorly in terms of symptoms and in terms of flow rate to an alpha blocker. It's very important to recognize that, but you don't know that if you give a patient an alpha blocker because we normally don't do an ultrasonography, or it's not recommended in the guidelines. This is from Japan, and it shows also 5-ARI treatment is dependent, so the success is dependent on it. And if you have a large intravesical protrusion, you have a substantially higher failure or retreatment rate on dutasteride compared to those with no protrusion. So both alpha blocker and 5-ARI treatment somewhat influenced. This is the question: if a patient is in retention, will a trial without a catheter work? And the trial without a catheter will work successfully in 74% of grade 1, but only in 30% of grade 3. So those patients who have a substantial protrusion may need a surgery right away. The trial without a catheter may be a frustrating experience. This is a paper from 2010, again from Dr. Fu's home institution, where he asked the question about clinical progression in patients on active surveillance. These are patients here on the left-hand side. They are not medically treated. And depending on the grade of their protrusion, they progressed between 7 to 19 to 49%. The right side focuses on patients on drug treatment, but the left side are untreated patients. Now, this is not published data. I show you this because it's kind of interesting in this concept. Years ago, the NIDDK sponsored a trial with Botox. Now, we know now that Botox is actually not effective. It's more or less just a placebo or a sham effect. But the NIDDK sponsored a multi-center trial in the United States treating patients with Botox, and I insisted on studying the intravesical protrusion and other parameters, but I'm not talking about the other parameters. I'm just talking about the intravesical protrusion. It did not correlate with prostate volume or PSA or symptom score or age very much at baseline. And actually, we divided them in 4 groups, namely no intravesical protrusion, and this would be the Fu categories 1, 2, and 3. And these would be the people without any intravesical protrusion. So at baseline, the symptom score, impact index, and flow rate were the same in all groups. But when those patients were treated, there was an overall improvement in symptom score and in BPH impact index of 7.5 points and 2.7 points with the BPH impact index. Stratified by the intravesical protrusion, the improvements ranged from 9.3 and 3.4 all the way to 5.5 and 1.7. So when going from patients without any intravesical protrusion to those with the largest intravesical protrusion, the symptom score improvement decreased by about 50% almost. So you see in this trial, which was not set out to study this, and where we gave Botox, which is essentially a sham treatment, there was a stepwise decrease in efficacy, quote unquote, depending on the degree of intravesical protrusion. So to me, it's interesting that the European guidelines recognize that, and they recognize actually the need for looking at the IPP, but they say the IPP is under evaluation. The AUA doesn't really recognize it in their guidelines, and I personally think that since this intravesical protrusion has been shown to correlate with urodynamic obstruction, it predicts success or failure of a trial without catheter, it predicts a response to ARI and alpha blocker treatment, it predicts a placebo response, both magnitude and the natural history, and the outcomes of conservative treatment. And since it is of such great importance, I think new guidelines should incorporate prostate ultrasound imaging at baseline to appropriately alert our patients to this and make appropriate treatment recommendation. And with this, I feel there is room for more research to look at learning curves, inter-rater variability, and certain thresholds. Maybe the thresholds are not the best thresholds, but there's room for academic work in this area. A few words now about post-void residual urine. I feel that post-void residual urine is in the guidelines also handled very strangely. The AUA guidelines say it can be measured by a non-invasive ultrasonography, and it's mostly a safety parameter, without saying really what does it mean, a safety parameter. And it's both the BPH guidelines say that and the AUA urodynamics guideline. They say it's a safety parameter. Well, that's fine, but it's up to us what it means and to be safe or unsafe, and what is significant urinary retention, right? Nobody knows that. The EAU guideline makes the recommendation as a routine part of the assessment, but also doesn't go into great detail of it. The problem with the residual urine in the management of LUTS and BPH is that it varies from day to day within a patient. There is a lack of precise definition, for example, whether it's a precipitated or a spontaneous total retention or a partial chronic urinary retention. The risk thresholds are not well defined at all, in my opinion. And the literature that we have at our disposal is very limited. Why? Because in all BPH treatment trials, we enroll patients whose residual urine is under 200, under 300, whatever the threshold is. We just don't study men with higher residual urines. So it's a poorly researched parameter in LUTS and BPH research. Reginald Bruskowitz showed many years ago in individual patients how extraordinary the variability in residual urine is from day to day. This was published in 1982, and in those days he daily catheterized the patients because we didn't have the handheld scanners for residual urine and demonstrated that. Currently, the definitions of PVR is such that an ounce or less is considered normal, and everybody may have that. The PVR is the amount of urine that is not emptied and remains behind, and it is known that it may increase both as a result of obstruction or as a result of a weakening emptying mechanism. The parameter that I think is of greater use than the residual urine alone is the voiding efficiency, which is calculated as the voided volume over total volume, residual and voided volume, and it comes as a percent number. And we shall see how that plays out in the literature. The question that is behind the safety recommendation on the AUA guidelines is the following. If a patient with LUTS and BPH is seen and he has a certain amount of residual urine, is his clinical course more like this, that he has a modest residual urine and suddenly he goes into retention? Or is the typical course of a patient more like this, that the residual urine goes up stepwise, time after time, until eventually he's in total urinary retention? Because that's what implied in the suggestion that the residual urine is a safety parameter, without going into any kind of details on that. Well, these are age-stratified normal values developed by Christian Oelke from Germany in the World Journal of Urology 2011. And you can see that in normal men stratified by age, there really isn't much of a difference in the post-void residual urine. And when you look at the only study that looked longitudinally in the participants at residual urine, you really come to realize that the changes in a single man over time and this is this plot here, in the Olmsted County study, is very small. It's like a cloud of dots, and they form a line, but the slope is not at all like that. The slope is very, very flat, with a very slight increase over time. So it seems as though in normal men, the increase in residual urine over time is very, very minimal. Christian Oelke asked the question whether residual urine is helpful in predicting bladder outlet obstruction, and I draw your attention to this line, PVR above or below 50. Unfortunately, the positive predictive value, the negative predictive value, and the sensitivity is miserably. It's basically 50 to 70%, so it's not at all useful in this particular cohort. Similarly here, Denuncio published that residual urine between Schaefer obstruction less than 3 and over 3 category, no significant difference in residual urine with no p-value. So residual urine alone is certainly not a good parameter to determine whether a patient is obstructed or is not obstructed, i.e. does need or does not need an intervention. A lot was made of the MTOPS trial finding that the median residual urine, which was 39 milliliter, distinguished in the placebo group of MTOPS men who did progress versus those who didn't progress. But if you look at the absolute progression rates, the difference, oops, I drew this wrong, was not all that great, you might agree with me. I looked at the residual urine in the MTOPS trial a little bit in greater detail, and I noted that the baseline residual urine did not correlate strongly with age, symptom score, prostate volume, peak flow rate, or PSA. And then I asked the question, what are the quartiles of baseline residual urine? Well, these were the quartiles. There was 1/4 of men who had a residual urine of 100 or greater, and the other 3 quartiles had either negligible, 10 to 40, or 40 to 100, right? And you can see that there was no difference in age, symptom severity, prostate volume, and peak flow rate between those 4 quartiles. When you ask the question about clinical progression in MTOPS, you can see that in the placebo group, the group of patients with a residual urine of over 100 had a risk of clinically progression of 1.42 compared to the base group of less than 12. So there was a small increase, and the group with 100 or more had a significantly increased risk in the placebo group, but not in the treatment group, just in the placebo group. And that's shown here graphically. You would argue that this is a disappointing ROC curve. So if you look at the placebo group alone, what did it predict? What progression did it predict? Did it predict overall progression, symptom progression, or urinary retention? And disappointingly, it did not predict strongly urinary retention. It predicted more so overall and symptomatic progression, not urinary retention, which you would think it would over time. So then I looked at the numbers and I asked the question, what is in patients who eventually go in the placebo group in MTOPS into urinary retention, what is their baseline residual urine? What is the last recorded residual urine before the retention episodes? And so when you look at that question, basically you'll see that in the group of patients in the MTOPS placebo group who went into retention, this is the baseline, around 100, and this was the last recorded residual before retention. So, this is the average, and this is the last recorded before the retention episode. So in the placebo group in MTOPS, at least there is a suggestion that there is a progression of the residual urine from baseline to a higher value on average in the course of the trial, and then the last noted residual before the retention episode was higher yet, going from 100 to 140. And the critical number in the MTOP study was 100. This risk prediction is not particularly strong, And in the treatment groups with doxazosin and finasteride in combination, it is not any stronger, but the tendency is there as well. Please look in the placebo group and in the doxazosin group. Baseline, average, and last recorded PVR. So we can say that in the MTOP study, which is the longest and largest numerically group of patients that had quarterly PVR measurements by the nurses in the study visit, high baseline PVR predicts progression in the placebo group. The patients who experienced retention had higher residuals at baseline and at the last visit before, suggesting that retention is the end result of increasing amounts of PVR. But it's overall not a strong predictor of this progression. Nonetheless, I do feel that this data is the basis for a lot of research and a lot of clinically based research that can be done to better understand the natural history of residual urine, to better understand thresholds that predict natural history, and that should prompt us to either initiate treatment or to continue treatment or switch from one treatment to another, maybe to surgical treatment. So there's a lot of room for research in that area, and I outline it here. We need to better define absolute and percent changes of PVR. We need to better define whether the voiding efficiency plays a greater role than the absolute number of PVR. We need to understand the contributions of other factors, so concomitant medication, comorbidities, constipation, etc., plays a role in that. And unfortunately, looking back at randomized trials is not very helpful because patients with higher residual urine were usually excluded from those studies. So I visited in these 20 minutes with you two things that I think are of interest and for residents and fellows and young academicians of interest in terms of doing clinically patient-based research, namely this issue of intravesical protrusion, middle lobe, whatever you want to call it, which is a wide open area for research in my opinion. The issue of post-void residual urine, definitions, thresholds, natural history, how it interferes with treatment algorithms. And then there are two other categories, the TUSO underactivity and nocturnal polyuria and nocturia, that I didn't have the time to get into it. So those are some of the areas in LUTS and BPH where I would like to see clinical patient-based research focused on, and what I would recommend for those who are interested in that. So I stop at this point and be happy to address any questions regarding this last talk or any of the talks as you wish. And I believe we have a brief break or something at this point.
So thank you very much, Dr. Orborn. Dr. Orborn has been talking nonstop for 2.5 hours. I think it's only fair to allow him a 15-minute break. We're actually just on time. And he'll be available in between to answer some questions. Plus, after the break at 10:15, we'll have case discussions. We might be able to squeeze some questions there.
Yeah, so the case discussions, I have basically some cases that I present some baseline data and some treatment option, and so we can have either from the audience or from the podium some. And I, on purpose, incorporated some of what I just now talked about into the case discussion, so hopefully this will be useful to reinforce some of the points that I was trying to make.
Okay, regarding the case discussion, I think Dr. Raed Azhar, the chairman or the head of he suggested that the chief resident should be the first one to answer your question. Okay, so please, all the chief residents, don't hide. Come forward so we can see you. We can see you from here, by the way, okay? So you have to move forward. So you'll be the first one to answer the question of Dr. Orborn, and if you fail, then we can ask the most senior guy.
There's no fail, actually. So many of those cases, you know, there are options, and you know, but one can give reasonable arguments for one or the other. And I'm trying to just bring home some of the points that I made earlier. Good, thanks.
So please, Chief President, move forward, please, for the next session. It will be very interesting and enjoying, please.
So we'll start at 10:20, not 10:15.
Good.